Hello. I might say bon dia, although it's a little bit late, but I know after lunch you shouldn't say. Dear ladies and gentlemen, and dear colleagues, it's a pleasure for me to be invited by the Congress and especially by Contatti Medical Company to present some data, recent data about two different cardioplegic methods. The Nido method, very popular in, I have realized, in South America, and the other one is the so-called HDK solution. So I will give you some experimental data, at the end some clinical data, but before I present our data, our recent data, never been presented before, this is for the first time, I will give you some data, some information about the neonatal heart. It was a wonderful study being done by Dr. Wittnich from Toronto, and she demonstrates the difference between a female neonatal heart and a male neonatal heart. Regarding ischemia, you see the ATP content is lower, lactate production is higher, and the cessation of glycolysis, anaerobic glycolysis, happens earlier. Furthermore, if we compare the left and the right ventricle of the neonatal heart, you see even during aerobiosis, there is a difference. The phosphofructokinase is higher, the activity, as well as the CK activity. During ischemia, ATP decreases faster, lactate increases higher, and the glycogen content is higher as well. So, let's speak now, or let's move to myocardial protection. It is the wrong way to think myocardial protection only depends on cardioplegia. No. It depends on the regimen of the extracorporeal circulation, the procedure as well. I will not and I cannot speak about procedures, but I can tell you very shortly, some details about the extracorporeal circulation. Boston has published a long time ago the difference between the alpha-stat system and the pH-stat system. And you see in these 182 children less than 9 months old, there is a difference some hours after the operation. There is a higher use of inotropic support in the alpha-stat group comparing with the pH-stat group. Another aspect is related to what happens after ischemia. Neonatal lambs were protected by potassium cardioplegia. I'm convinced it was St. Thomas's solution. 2 hours of ischemia and 60 minutes of reperfusion. And you see the perfusion pressure after the declamping of the aorta decisively influences the recovery of the myocardial O2 consumption. If you start at a higher pressure, the recovery is poorer than if you start with lower pressure and then slightly increases. Experimental data. The myocardial tolerance to ischemia depends on the ischemic stress. That is quite normal. That means ischemic time and the temperature during ischemia. That means ischemic stress is higher if the temperature is higher or the cross-clamp lasted longer. The other thing is the immature heart or neonatal heart is a little bit different because now we have to distinguish between these acyanotic and cyanotic children. And you see, There is a study being published a long time ago. They looked for acyanotic infants and cyanotic infants, and they looked for the decrease or for the release of the MDA. And you see the difference. In the cyanotic group, the release is by far higher than in the acyanotic group. Now, can you move? Now, what different methods do we have? We have the crystalloid and the blood-containing solutions. You see, the crystalloid, that was Mark Brainbridge and David Hurst from St. Thomas's. They firstly presented potassium and magnesium arrest. Brett Schneider, we demonstrated the histidine buffer. The blood-containing solution, I think I only will focus on the last two ones. The Buckback methods, they had a ratio of blood to crystalloid 4:1, while Del Nido presented a ratio of 1:4, blood to clear. And the histidine demonstrates the buffered solution. Next, please. And you see, no, one back, please. Sorry. Oh, yeah. So now let's look, what are the main components to target on the neonatal heart protection? Next. What are the components? Sodium, potassium, calcium, magnesium, and buffer. These, to my opinion, the most important components. Let's start with the sodium. Next, please. Here you see an interesting study, although I have to criticize. They demonstrated the influence of intracellular solution versus extracellular solutions. But I have to criticize what kind of solution do they call an intracellular and what kind of solution do they call an extracellular solution? Very simple. They argue a sodium content of only 26 millimolar is extracellular. That is wrong. Today we know the extracellular solution, that means a sodium concentration of about 120 to 130 millimolar. So, secondly, the intracellular solution only contained 15 millimolar. Experiments on piglets, they were cross-clamped for 24 hours and then tried to recover. And you see the intracellular solution recovered by far better than the extracellular group regarding the left ventricular end diastolic pressure. So next. Next, the second argument is, why is the intracellular solution, that means low sodium, superior? You see here very old experiments looked for O2 consumption of the left of the myocardium. These were adult dogs, and you see the lowest O2 consumption could be achieved if they administer a low sodium content. Low sodium means the so-called Brett Schneider solution in comparison to a higher potassium content. And secondly, you see the range is the lowest if they look for if you compare with the Brett Schneider solution. Next. A further advantage is related to the osmotic space available to add a highly concentrated buffer. If you only have a low sodium content, then you have an osmotic space available to add, for example, a highly concentrated buffer. If you use an extracellular type of solution, there is only a small osmotic space to add for example, a buffer. Next, please. So we conclude only low sodium solutions offer the opportunity to add a highly concentrated buffer. Now let's move to calcium. Sorry, it's long distance. Give me next, please. Next.
As a problem.
Okay. It works? Okay. Now, there is a law of nature. This is very interesting. The law of nature says the sodium, the intracellular sodium content square divided by the extracellular sodium content square is the same if you divide the intracellular calcium by the extracellular calcium. Now, what do we know? We know the extracellular concentration of calcium and the sodium concentration. For this example, I have chosen 1.5 millimolar. And you see 1.5 square divided by 150 square millimolar square. This is the result. What happens if we now reduce the sodium content to 1/10? That means from 150 to 50 millimolar. We know the result of this equation. We know the extracellular sodium content, 50 millimolar, and we have to look for the calcium. And the calcium content is 0.15. That means the calcium must be reduced to 100 if you reduce the sodium content to 1/10. Furthermore, we have, looking at St. Thomas's solution, they compared what is the best calcium concentration, and it is obvious the best results could be achieved if they reduce the calcium content to 0.3. Now you may argue this is completely different if you take the blood cardioplegia. And experiments in neonatal piglets, in the hypoxic group, it was very important to lower the calcium concentration, and if you lower this, then will get the best results. Magnesium. Please keep in mind, we have decided to lower the calcium concentration, and here, if you have a hypocalcemia, then it is important to increase the magnesium content, and this will lead to a further protection or a better protection of the myocardium. Again, neonatal piglets have been used. Now, let's move to the buffer. It was a wonderful study from Dr. Julia in Los Angeles, in San Francisco, and he demonstrates that the puppies produce much more lactate during the same ischemic time than the adult dogs. So, the efficiency of a buffer depends at first on the concentration. That is quite clear, but we have a problem. And the problem, it says, the osmolarity. And the osmolarity should not be above 300 milliosmol. Therefore, the osmotic space being available, the limiting factor is 300 milliosmol. And again, I have shown this slide before. The osmotic, if you use an intracellular type, you have the osmotic space, but the limit is the osmolarity. Secondly, the pK value of the buffer is important, as I will demonstrate. Oh, no, sorry. This is, for example, at first the pH. The pH of the buffer or of the solution itself was demonstrated in our group. And you see, the pH should be between 7.0 and 7.5. This is the optimum. The parameter we used was the ATP content of 4 micromolar. we looked for the period until this critical ATP concentration has been reached. That means the pH should be between 7 and 7.5 initially. What buffer do we have? We have the hemoglobin buffer, but if we want to avoid a blood-containing solution, we have the THEM buffer. The pK value is not very good. The bicarbonate buffer does not work during ischemia. The histidine buffer is acceptable but not ideal. The carnosine pK value is very interesting. What is carnosine? Carnosine is a double molecule from alanine and histidine. So it's very interesting. Later on I show you some data. And I have added acetate because Del Nido solution contains acetate as a buffer. But I couldn't find any data. What is the pK value? The pK value is 4.8, but I do not find any data about the temperature at which the pK value was measured. So this is the HDK solution, and you see the buffer here at a very high concentration of 180 millimolar for histidine and 118 millimolar for histidine hydrochloride. Secondly, this solution has two free radical scavengers. The first one is histidine, and the second one is mannitol. And therefore, we have been never faced to ischemia reperfusion injury using this solution. Now, if we compare now HDK and Del Nido, we cannot compare only the solution. We have to compare what happens if these solutions are administered to the patient. And therefore, I only can make an approximate the data for Del Nido solution because it depends on the blood containing content of sodium and others. So let me start with potassium. Potassium 10 millimolar with HDK and about 26, more than 20 millimolar with Del Nido. Sodium 15 millimolar with HDK, but about 150 millimolar with Del Nido. Calcium and potassium and magnesium. Calcium is low in both solutions. Magnesium content is very high with the Del Nido solution. It is increased with HDK. Buffer, we have a high concentration of buffer as been demonstrated, and more or less lower concentration acetate and bicarbonate in Del Nido solution. And finally, lidocaine. Lidocaine at 0.5 millimolar, that means 13 ml of lidocaine being put into the solution. Let me look at this special aspect of lidocaine. We have measured the myocardial pH during ischemia in dog hearts, adult dog hearts, without reperfusion. And you see here what happens. Independent of different cardioplegic solutions being administered, the pH decreased. This red dotted line demonstrates the critical limit for resuscitation of the myocardium. This is completely different to the human body. The myocardium can be resuscitated up to a pH of 6.0. And you see two different crystalloid solutions, synthomasus and custodiol. Now, you may argue this is interesting, this is the effect of the buffer. No, that is not correct, because what must we do? We have to compare the pH at the same lactate content. Then we can decide it is a buffer effect or not. And here we did it. You see, the buffered solution will will not reach the critical limit even if the lactate content is very high, while it completely failed with symptomasis solution. What is the consequence? The consequence is to reperfuse, try to push to elevate the pH towards the alkaline side. That is the only reason for cardioplegic reperfusion. And we use this parameter to measure the influence of procaine. To my opinion, procaine is similar to lidocaine. And what happens? Very interesting. If we use procaine, the pH lactate curve is shifted towards the alkaline side. What does it mean? It means the permeation of protons is impaired by lidocaine. Secondly, if this is impaired, if you administer procaine or lidocaine, you cannot use the total buffer efficiency in the extracellular space. That is the consequence of these experiments. Now, coming to the second part, to the experimental protocol. We used neonatal piglets, 4 days old, 2 kilograms of body weight, with, I think, the piglet is the best animal model we can use to evaluate the influence on neonatal hearts. Pre-medication was done by midazolam and ketamine. Anesthesia was done with midazolam, fentanyl, and pancuronium. We intubated these piglets and ventilated it with isoflurane. We made a stenotomy. Then we cross-clamped the upper and lower caval vein. We cross-clamped the aortic root, and then we made a single-shot cardioplegia. We administered Del Nido 1 to 4, 40 ml in 4 minutes, and HDK 80 ml in 4 minutes as well, as recommended always. Then we harvested these hearts and put all the hearts into a thermostat at 25 degrees constantly, and we measured for 24 hours. So we have different methods to evaluate myocardial ischemia or the efficiency of cardioplegia. The first one we used was biochemistry. We looked for the ATP decrease. You see, we started 0 at the apex, 60 minutes, 120 minutes, 180 minutes. And these are the results. It is obvious, independent what you administer, the ATP, as being expected, decreases. The difference after 120 minutes is significant between HDK and Del Nido. Now I will give you some interesting data concerning another buffer. Oh, sorry. Okay. Here we have used, as mentioned before, the carnosine buffer, and in adult dogs, and you see what happens if we have to decide what is superior and what is inferior. Then it is clear carnosine seems to be superior regarding ATP decrease. So next parameter to evaluate, I'm sorry. Give me please. Morphology. Now we look for morphology. Next, please. And it was completely surprising. Although the ATP protection was superior with carnosine, it completely failed after 300 minutes of ischemia and 20 minutes of reperfusion. You see these dramatic disruption of myofibrils. So we conclude, ATP is an interesting parameter, but it cannot predict the quality of the method being administered. Next. Now, therefore, we followed these thoughts and looked for morphology during 3 hours of ischemia at 25 degrees. Next. The first are the light microscopic findings. There is no difference, a wonderful protected myocardium, either with del Nido or with HDK. Next. After 60 minutes, there is no difference, to be fair. It seemed to be a little bit lighter in this area, but that we cannot judge in this way. Next, please. After 180 minutes, perhaps you can realize there are some irregularities in this area, enlightenment in this area, while the HDK protected hearts looked wonderful. Now, consequently, we have to look for the ultrastructure. Next, please. After 0, nothing, wonderfully protected myocardium. Next. The same happens with HDK. After 60 minutes, it is well protected. You see some edema as being expected. Next. And the same, almost the same happens with HDK. And now, what happens after 3 hours of single shot cardioplegia? Next. You see this an equivalent picture with equivalent with carnosine, and this is HDK, a wonderfully protected myofibrils. The Z bands look brilliant. You see some crystallizes, while these mitochondria are completely destroyed. So next. There is an unsolved problem, to my opinion, in neonatal cardiac surgery, and this is called edema. It depends firstly on the procedure, for sure, and it depends on the cross-clamp period. The higher the ischemic stress, the more often occurs the edema. And up to now, we have no idea how to solve this problem. Next, please. We are, I will say, the first who could demonstrate how it happens. We compared neonatal hearts, 4 days old, with adult pig hearts, 3 months old. We have chosen ischemia, pure ischemia at 35 degrees to provoke the ischemic stress and the influence. And you see, even after 10 to 20 minutes, the edema develops, while in the adult heart it remains constant up to an hour. The difference between these two curves is highly significant. How could we measure this edema formation? Next, please. We used impedance spectroscopy. And now I ask you politely to follow me. What does it mean, impedance spectroscopy? Next. Next. Firstly, if we administer a current flow through the extracellular space, low frequencies, that means about 100 hertz, the current flows only through the extracellular space. And we call this the ohm resistance. If we now increase the frequency up to 1 megahertz, the current only flows through the intracellular space, passing capacities of mitochondria, membranes, and so on. And we call this the capacity resistance. Now, let's do and let's measure. This is our measuring probe. You see, there are two electrodes that inject the current, and two electrodes that measure the changes of the voltage. This is a typical neonatal heart, and this is the comparative study between Del Nido and HDK. In the beginning, there is no difference, but after a long time, in this case after 500 minutes, the difference is highly significant. How can we measure this parameter? We calculate, and this is worldwide accepted by the physicists, if you divide low frequency by high frequency. Secondly, it is interesting that the Del Nido values seem to re-increase. And we have measured different solutions and different methods. Among them were pure ischemia at 25 degrees. And you see the pure ischemic hearts re-increased. Any re-increase means an injury of membranes and capacities intracellularly. Secondly, by this method, we can evaluate the gapped junction closure of the myocardium, because these are some data from a colleague who is involved in our experiments. If they administered HDK solution into guinea pig hearts, you see after about 100 minutes, the electricity increases. But if you administer heptanol is a blocker of gap junctions, within a couple of minutes, the increase happens. That means the gap junction closes. Now, if we compare Del Nido with HDK, you see, the gap junction closure happens earlier at this frequency in the Del Nido group in comparison to HDK. This difference is significant. The electricity at a very high concentration, very high frequency, is significantly different to HDK group. The reason is very simple. It depends on lidocaine, nothing else. And this does not have any, it does not have any negative impact on the outcome. So what is the situation worldwide? There was a wonderful survey in the States. What do some centers use in North America, South America, or others? You see, in South America at that time, that was in 2012, a vast majority used symptomatic solution or potassium rest. Some used HDK, while Del Nido was not used at that day. That has completely changed today. That means it depends on the location worldwide where Del Nido is used or HDK or others. So what are the general administration guidelines? We always recommend antegrade perfusion, and the perfusion volume depends on the age of the babies, because the younger the baby, the higher must be the volume being administered, because the coronary resistance is lower in the very young children, in the neonates, than in the adult hearts. 4 minutes of perfusion and solution temperature should be 6 to 10 minutes. We have measured in children what happens during cardioplegic perfusion with the O2 consumption. And you see, that was the inflow PO2, and this is the coronary venous effluent PO2. and it decreases, although the perfusion rate was kept constant. The same was done by Dr. Angeli from Bologna, and she measured in neonates, the red columns, the O2 consumption during cardioplegic perfusion, and she could demonstrate a decrease less than 0.1 ml. Why is this necessary? Because the lower the O2 consumption is, the higher is the creatine phosphate content. Whether this has any clinical impact on the outcome, I do not know. This is only for scientific reasons. So replegia. With HTK, there's no need for replege for 3 hours of cross-clamp. Comparing Del Nido and HTK in the US, it is interesting that Del Nido was re-administered after 44 minutes, while HTK was re-administered after 40 minutes. That means that is a shift of paradigm, that there is no need for reperfusion, but they did, because they are not used not to reperfuse. In the cardioplegic reperfusions, and you should not forget, are harmful to the neonatal heart. You see some references. If you look into the literature, most of the authors prefer single administration, single dose, while only one paper was reported on multi-dose. And you see what happens with rabbits, neonatal rabbits, either single dose cardioplegia or multi-dose cardioplegia. The results after single dose cardioplegia were superior. Now, another single perfusion and replege every 20 minutes for 2 hours of arrest, it is obvious the replege group showed inferior results. And what is now with Del Nido and HTK? It is interesting, there was a study in North Korea comparing Del Nido versus HTK, 2 hours of arrest, replege every 40 minutes, HTK and Del Nido, and they looked for the mitochondrial scoring of these red hearts, and there was no difference. But if they do not replege, the results were obviously superior. A study from Beijing compared St. Thomas's versus HTK, and they looked, ischemia lasted for more than 3 hours in the St. Thomas's group because they replege every 30 minutes, and they did not replege in the HTK group, and the cross clamp was less than 3 hours. The CK value at the second day was significantly lower, and mortality rate as well. Dr. Angeli from Bologna being mentioned before, she measured the troponin I loss during in these babies with a TGA, and no replege up to almost 100 minutes. And she could demonstrate that you can save time if you compare it with blood cardioplegia, can save time if you do not replege. A study from Russia demonstrated a special group of 7.6 hours of age, and they used HTK solution without replege, cross-clamp was an hour, and mortality rate was 0. So now, what is the efficiency of single-shot cardioplegia if you look for different methods? The first one, a safe cross-clamp time if you use hypothermic intermittent cross-clamp. I will show you some data about this. We have measured the lactate washout after ischemic time in the first 20 minutes of post-ischemic reperfusion. If the heart have been protected by HDK, after 10 minutes there was a reuptake or a stop of washout of HDK, of lactate. And what do you think happens in the ischemic group with intermittent hypothermic cross-clamp? 15 minutes of rest only. And you see, there was no trend. All hearts could be weaned off of bypass without problems, but it is interesting from the metabolic side that this mode of protection is not safe. So, coming back, Buckberg is safe for 40 minutes of single shot. St. Thomas's is safe for 40 minutes. Del Nido is safe for 60 minutes, and HDK is safe for 60 minutes as well. Now, 60 minutes is clear. What happens after 60 minutes by single shot? Safe up to 90 minutes, there's no doubt. But with HDK, you have a safer rest without repleach for 3 hours. So I come to the end. Del Nido is by far superior to Buckberg's cardioplegia. Del Nido method also demonstrates, and that is very important, that Buckberg's assertion regarding the significance of blood and its oxygen carrier function failed. Since now, with Del Nido, cardioplegic reperfusions have become less frequent. Otherwise, it should be more. Del Nido method is a very useful contribution to facilitate cardiosurgical practice in neonates. HDK solution is the only highly buffered cardioplegic solution available worldwide. In neonates, Del Nido solutions offer the same protective efficiency, up to 60 minutes of ischemia, because cardioplegic reperfusions are unnecessary. But if ischemia exceeds 60 to 90 minutes, HDK gets superior, since HDK solution guarantees safe protection for 3-hour ischemia without reperfusion. And finally, since the neonatal heart is not a small adult heart, cardioplegic reperfusions should be avoided. I thank you very much for your attention.